All right, thank you for joining us today for our Systems for Action PHSSR Research and Progress webinar. Our theme today is Bridging Health and Healthcare. Our topic is leveraging a health information exchange innovation to improve the efficiency of public health disease investigation. I'm your moderator, Rick Ingram. I'm a professor at the University of Kentucky College of Public Health. Our presenters today are Debra Revere. She's a research scientist at the Northwest Center for Public Health Practice at the University of Washington School of Public Health. Her research uses qualitative and mixed methods to focus on understanding the information and communication needs of public health, including how HIE, associated data sources, and access to information can enhance and support the work of public health practitioners. Another presenter is Ian Painter, who's a biostatistician at the Northwest Center for Public Health Practice. His areas of expertise include disease surveillance, public health informatics, public health services research, data quality, and the utilization of EMS services by limited English proficient populations. Our last presenter is Janet Baseman. She's an associate professor of epidemiology at the University of Washington School of Public Health. Her research centers around applied epidemiology and public health practice, strategies for improving disease surveillance systems, and public health informatics. She's also adjunct faculty in the Department of Health Services and is a member of the Northwest Center for Public Health Practice research team. So, having said that, let's start. Debra, would you like to start?
Okay, so you've already gotten the introduction. Do I do that? Okay. No, I don't do that. Hold on. We're working. Do I go down? Oh, okay. Just I'll click there. Okay. So, welcome everybody. Thanks for attending. We're going to be talking about a natural experiment that has been conducted here at the University of Washington, and talking about some of the challenges of conducting public health systems, services, and informatics research. A lot of the challenges that we'll talk about is given these kinds of projects involve and require the involvement of people, organizations, and technologies, and the fact that things can change, and that your initial idea, as wonderfully formed as it might be, might change because the unexpected happens. We're going to talk about the lessons we've learned regarding needing to have a backup plan or two, and some of the ways in which conducting a natural experiment research, we had encountered a lot of twists and turns along the way, but ultimately we can assure you we have a very happy ending to our presentation. So, just for context, so the primary objective of our project was to investigate the impact of a new technical service that was being implemented within the Indiana Health Information Exchange. And it was being implemented by the Regan Street Institute, and it's the project at the Regan Street Institute I'm also involved with. This new service that was being developed was working to automatically fill or pre-populate communicable disease report forms with electronic clinical data that was available through the Health Information Exchange. And so in other words, to leverage the availability of this data, populate these forms, and then and populate them before in a clinic before the forms had to be sent to the public health department, and that public health department is the Marion County Public Health Department in Indianapolis. So the goal of this new service was to streamline this reporting process for clinicians, as well as to reduce the reporting burden on healthcare providers in the Health Information Exchange. And the project was strictly looking at the impact of this intervention on clinical processes and with the goal of having better data quality, improving timeliness, and reducing burden of reporting. So it would seem that a technical innovation like this could really benefit public health as well. There would be more timely or efficient delivery of data, but it wasn't really known how this new service might also impact public health, which is where our project came in. So the goal of our project, at least originally, was to look at the impact of this intervention and it's on improving disease reporting, case follow-up activities, timeliness of reporting, timeliness of assessments of the disease burden in the community. So this was our project ideal. So we have our plan A, and we have a really wonderful vision. So, you know, you have your inputs, your activities, your outputs, your outcomes. These are ways of formulating a plan that we all start with. However, so this plan depended on implementation, again, of this new pre-populated form service. And this slide just shows the process that this new service would, how it would be implemented. So normally, when an abnormal or positive lab test result is identified within the Indiana Health Information Exchange, it's identified through something called the notifiable condition detector. And I know there's been another presentation in the series by Dr. Brian Dixon where he went into detail about the notifiable condition detector. And what that service does is it flags results to alert clinicians to a positive lab result test, for example, for something like tuberculosis. So the additional piece of this process that was added in is that pre-populated form that you can see between the notifiable condition detector and something called the Docs4Docs service, which would deliver the pre-populated form to primary care providers. And in this project, we the communicable disease report form could then be printed out, checked for accuracy, and then it would be sent to public health as normal. So originally, again, our good intentions, one of the things in doing research and conducting a natural experiment in public health is that, again, you know, we have the people, organizations, and technologies, and that, and sometimes things change. So we had our vision, and then what we found was that we needed to change the time period. We had to make some course corrections. We found that some data was too unstructured to be used. We found that other confounding variables kind of derailed things. We had to scrap our original plan, re-envision our project, and hope that our funder allowed us to make these changes without yanking any funding, which, of course, RWJ did not. Otherwise, we wouldn't be here today. But so basically, conducting a natural research, experiment research project is, we've come to look at it as kind of an uncontrolled experiment. So you need to have a contingency plan or two, being mindful of, you know, there's risks and needs to manage all of your activities. So we had our plan A. We made up a Plan B, a Plan C, and a Plan D. And that's what we're presenting today, something that started off very straightforward and then moved on to with unexpected process to a certain extent. So just so that you know, within these two projects, there were a lot of interdependencies. So there were different data was collected for what I'm calling the AHRQ project, which was the funder for Regan Street Institute for implementing the pre-populated form service, and then our project. So the AHRQ project is, again, very clinically focused, and the RWJ project, our project, was also quantitatively focused, but focused again on public health. So one of the things originally that we had wanted to do is collect, as a measure of burden, collect public health telephone system logs so that we could see how much time investigators were spending when they were conducting investigations. And that data, it ended up was not available because the phone system changed between the time that we first made wrote our proposal and when we were funded. So we scrapped that, we went to Plan B, we revised our definition of burden, and then focused more on individual public health investigator caseload to determine burden. The next thing that happened that was unexpected was that there were technical issues in deploying the new pre-populated form intervention. So what happened there is that we had to look at, we had a more limited set of data that we could collect, and we also then extended our timeline for data collection. So instead of the deployment of this new service occurring in mid-September 2013, it was deployed later. So then in March of 2014, unexpectedly, the notifiable condition detector service, which alerts the providers to a notifiable condition, so that they know that there's a form that will need to be sent to public health, that went down for a period of time. So that also interrupted our project, and we had to look at whether or not we could collect sufficient data during a short time frame. So basically at that point we then moved on to Plan D. And, okay. So what we did for Plan D is data were pulled from two surveillance systems. One is called Insight, which is data that is non-sexually transmitted disease data, and the other is SWIMS, which is the sexually transmitted disease data. So we were able to pull data for a baseline time period of January 1st, 2012 through September 15th of 2014, which covered the period before the pre-populated form intervention was deployed, a short time frame during which the intervention was in service, and then we looked at the post-intervention time frame. And our plan was to look at these data to compare pre, during, and then post-intervention time periods, looking at reporting volume, reporting timeliness, burden of reporting on public health as determined by the number of report cases that were handled by each individual public health worker on a per month or per condition basis, and the time for public health to complete or close a case.
Okay, thanks, Debra. So this is Ian, and I'll be talking about the data and the data analysis. So we worked with Joe Gibson at Marion County to identify specific disease codes to study in each database. So in the Insight database, we looked at codes for hepatitis B, hepatitis C, histoplasmosis, and salmonella. And in the SWIMS database, we looked at chlamydia, gonorrhea, syphilis, and syphilis reactive records. And for purposes of analysis, the syphilis category was really a combination of early latent, late latent, neurosyphilis, primary, secondary, and unknown latent syphilis. We had over the full-time period of the study about 3,700 records from the Insight database and about 48,000 from the SWIMS database. We did a number of data cleaning steps. Basically, we dropped any records where we were missing crucial data, such as a date or obviously a lab test, what the test was. And that dropped out very roughly about 10% of the records. And then we also removed records where there were date anomalies, which, for example, consisted of records which, for some reason or another, were kept open for an excessively long period of time, or where the date of the receipt of the result was before the date of the test, or other anomalies like that. And that dropped out about another 10%. So we lost about 20% of the data through either missing data or date anomalies. Chlamydia was by far and away the most common condition in the SWIMS data, and chronic hepatitis C for the Insight data. So we wanted to, in order to do the analysis, and we had planned to do kind of a pre-post analysis initially. We wanted to understand the context in which the data were being reported, in particular the reporting volume and the essentially the number of cases per investigator that were investigated, as these were things we'd have to know in order to figure out how to adjust for variations in our analysis. The first two plots here show the reporting volume by month. First of all, the bar plot on the left is showing for the Insight cases, and the second is for the SWIMS cases. Now, and there's a general slight trend downwards in the Insight cases. For the SWIMS cases, a small percentage of the cases are followed up for investigation, partner notification, etc. And so we also looked at those separately, and that is the third graph, the one on the right, and you can see that starting in 2000, at the beginning of 2013, there was a big increase in the number of cases which were investigated. When we drilled down on this by condition, we saw that this was the case for chlamydia and gonorrhea, but not for syphilis. And similarly, and so at this point we decided we needed to talk to public health investigators to understand exactly what was going on. So talking to the investigators, we learned that there was a concerted effort to follow up on more cases starting in the beginning of 2013 for chlamydia and gonorrhea. So at least that was we confirmed there's a good explanation for what we're seeing in the data, and there's certainly something we need to be aware of in terms of understanding before and after changes. For the Insight data, especially for salmonella, we saw some seasonal relation in terms of the seasonal association in terms of the number of cases that are being reported. For the, so that was kind of a look through the reporting volumes. We were also interested in understanding the context of the data from the point of view of the individual public health investigator perspective, so that we could understand if there were variations in case burden or in the people that were investigating the cases. And so we created some time course plots, and this is an example. It's hard to see the details, but basically each row represents a different investigator. Each investigator had their own code in the data, so we could tell who was looking at which case. And the x-axis is simply time, and this is showing markers where that particular investigator a case. So we can easily see that, for example, the second investigator stopped working on either stopped working on SPD cases towards the end of 2012, and that the bulk of the investigation, the cases are looked at, well, these are cases with interviews, were investigated by just a couple of investigators, with other investigators looking sporadically at cases. And so given this great high level of variability between the investigators and the kind of different time frames in which investigators were working on cases, we decided we would need to understand, investigate the effective investigators on the timeliness and closing cases reporting when we came to that analysis. Okay, so the two main outcomes that we ended up looking at were the time to receipt of a case and the time to close. And basically, the time to receipt is the time difference between when the case essentially became known that it was a case and when it was received by public health. We we calculated this time difference in two different ways. One way, it was simply in the number of calendar days between the date of the lab test and what we're terming the earliest date of any public health activity. And the reason why we've defined that date in that way is that the entry into the database sometimes could be different, could be in a different record. So we would take the earliest date from any of those records, which represented something happening in public health. And then we also looked at the time difference in terms of the number of work days, so days in which actually work was performed, so excluding holidays, snow days, etc. And we determined that simply by looking, since we have all of this data, looking at what days had any records processed on them. So with the idea that if someone was doing work, it would show up in the database, and if it was a holiday, there would be nothing happening on that day. And then we're also interested in seeing what happens by the day of the week, as certainly that can impact when lab tests run versus when lab tests are sent out, etc. So we observed the mean time to receipt, or the median time, was, I can't remember what it was. So, it's on the next slide. Okay, about 4 days. So this is just a histogram of the number of days. The majority of them close within 3 days. We saw quite a bit of variation in terms of the reporting time by, this is just looking at the SWIMS data, by condition. So in general, chlamydia took longer to reports took longer to receive than the other days. And we also saw quite a bit of time, and these are in calendar days for, depending on the day of the week of the lab result, and it's not too surprising, well, I'm not sure if it's surprising or not, but Monday seemed to be the quickest day. We also noticed that the reporting volume varied by day, the variation by day of the week in reporting volumes was different for the different conditions. So we think this is essentially represents variation in the actual practice of clinical health, you know, when people go into what kinds of clinics and so on. When we looked at the number of work days rather than the number of calendar days, we still see a difference between the condition, that's the graph on the right, but the difference in terms of the day of the week is somewhat reduced. So a lot of the differences in day of the week that we saw in timeliness was simply when laboratories are able to send out reports rather than anything else. Okay, and so the other outcome we looked at was time to close, and so this was the difference from when the report is received by public health and when the report is marked closed. And again, we looked at the number of, well, in this case, we looked at just the number of work days that between the two time points. And with the SWIMS analysis, we looked at, in particular, those with interviews separately from those without interviews. Okay, so for the insight data, we found that roughly half of the cases were closed within 17 work days. The median time to close a case varied quite a lot by condition, and it also varied by investigator, but there's also variation in terms of different investigators tended to concentrate on different times of cases. In the graph on the bottom right, you can see a histogram of the dates, the times, and you can see there's a strong kind of weekly effect of cases, I think, being essentially closed at the end of a week. So that's why we have these drops down at basically 7, 14, and 21 days. And we couldn't explain, so we saw differences between the investigators in terms of time to close cases. That wasn't fully explained by differences in the type of cases that the investigators looked at. And it wasn't explained by investigator case burden, and we measured case burden essentially by the number of cases that were open for an investigator at a time point. I should say on that aspect, we only had access, the data we had is only for these particular conditions, so we're only looking at the burden in terms of these conditions, and there may be other conditions, other cases that investigators were working on. And we saw a similar thing in the, well, I'll go into the SWIMS data in a sec. We saw differences in terms of time to close by condition. Some of that may be related to cases being left open to allow for follow-up tests results to come through. And the second graph here shows an example of the differences in time to close by investigator for the investigators which had more than at least 50 cases during a time period. We also saw quite a lot of variation in mean time to close by month, but we're not sure exactly why that is. In the SWIMS data, we have cases being closed generally on a much faster basis. So about half of the cases are closed within 4 working days. And the median time to close varied by month, but showed a clear decline from about 10 days at the start of the study to about 5 days at the end of the study. The majority of the cases did not have interviews, and for those cases, we saw statistically significant effects between the time to close and the condition, the public health investigator, the day of the week, and the mean number of cases per week. The cases with interviews, we saw an interaction effect between the condition and the investigator. Because of fewer cases for that situation, we have less power to detect differences. So that's something to be aware of. So this shows the time to close without interviews for the different conditions, and syphilis took the longest amount of time. The bottom graph shows differences in cases without interviews by investigator, and there's a very large amount of difference. This may reflect differences in the practices in terms of when investigators marked cases as closed. So our date of close was when it's marked closed in the database, which may not necessarily reflect when essentially the case is finished being investigated. We were also interested in looking at differences between providers. This turned out to be more challenging. We had in the 37,000 cases, we had about 700 unique providers. Many of those providers only reported 1 or 2 cases. And so in terms of analysis, we basically we only kept those providers, for analysis of effective providers, we only kept those providers with more than 30 cases, and that dropped about 1/3 of the cases. And again, there was a lot of noise, so it was very hard to make any conclusions. We did see some differences in terms of if we dichotomized it in terms of large providers who report more than 50 cases, and more providers report less than 50 cases. And we did see statistically significant differences. This is with interviews in terms of time to close, with condition, investigator, caseload, day of the week, and the mean number of cases per investigator per week. Now, in terms of looking at the effect of the intervention, our initial plan had been to do essentially do a before and after analysis, and the initial plan was that the implementation would be staggered over several different clinics, so that we would have different clinics coming on at different times. Because of the challenges in implementation, and because so few cases were actually received through the system, we could not do a before and after analysis. So instead, our plan D or E, I'm not sure now, we looked at essentially doing a matched analysis. So during the time period, and this is we could only do this for the SWIMS data, we received 25 pre-populated forms sent to public health. So what we decided to do is to compare those 25 forms with matched cases from the same period. And basically, we matched cases on the same condition, the same basic broad date range of receipt, basically during that time period, plus or minus 2 weeks. The difference in time to receipt, so not only during that time period, but within 2 weeks, because we know there's variations in terms of when holidays are. The same reporter and the same day of the week of receipt, as we saw the strong day of the week effect. When we looked at that, of those 25 cases, 13 of them could be matched to at least one control case, and the number of control cases they matched to varied substantially from 1 up until, I think, 87. Because of that difference in the number of cases, we ended up doing a multiple level hierarchical random effects model to basically account for differences in the number of controls that each case was being compared to. And then we basically looked at what is the time difference between the case and the difference in time to receipt or time to close between the case and each of the matched controls, and calculated the estimated mean differences from those. And basically from that we saw that the time to receipt was on average, our estimated mean difference of 2.4 days. So cases being reported through the pre-populated forms were received on average 2.4 days earlier. And the time to close was also shorter, but less so, 1.3 days than controls. And in terms of formal analysis, the 2.4 days was statistically significant, and the 1.3 days was not statistically significant.
Okay, thank you, Ian. So I'm just going to now draw some concluding thoughts and summary comments, and then we'll open the floor up to questions. So what we wanted to conclude with was a little bit about what we learned over the course of this project that we've just described to you. So we started with a very quantitative, data-driven project that was focused on measuring change in burden and timeliness of notifiable conditions reporting. And then that kind of turned into a more exploratory analysis that really engaged more with public health agency stakeholders who were reviewing and providing input, including confirmatory input on the inside and SLIMS analyses by the time we got to our final project plan. And ultimately, we really feel that what we ended up with was a stronger project than what we had even initially proposed, because the involvement of those public health agency stakeholders provided really important and significant course corrections to guide our work, guidance for the project itself, and also ended up generating the most important and some unexpected outcomes that we believe could really make a difference in their work. So in reviewing our analysis reports, this served to confirm our often changing approach and validated some of the findings we were seeing within a real-life context. So involving our public health agency stakeholders gave us the chance to take a look at some of their specific requests for analyses and then identify some missing opportunities for exploring the data that hadn't occurred to us. So for example, some of the public health agency stakeholders were not only interested in our reported findings, but found that looking at our findings by investigator, day of the week, condition specifically was kind of a new and useful way for them to look at their own day-to-day activities within public health. And specifically, being able to really see how investigators varied with respect to time to closing cases indicated to them that maybe some more training and better standardization would be useful to them. In addition, new investigators were being hired, and our reviewers thought that our findings could potentially inform the training of these new investigators. And reviewers also noted that seeing stratified levels of work by the different individual investigators could be a new way to look at their quarterly or annual workload. And viewing the work from a day of the week perspective provided insight into which days are the busiest. So our reviewers also indicated that understanding how day of the week information might contribute to some of the delays in their work and their workflow and increases in their workload would be valuable at their organizational level regarding staff planning and some policies that could be put in place or altered regarding division of labor and the workflows that would go along with that. Overall, we felt that reviewers found that the corroboration process reaffirming a lot of their internal organizational policies already in place that seem to work well was good, and also providing kind of a bigger picture perspective on the issue of provider reporting and the delays that exist that can really impact their public health processes and workload. And then this corroboration process also provided the opportunity for reviewers to give a voice to their general concerns about reporting work that public health depends on. And one reviewer had noted that provider reporting is the single most important, yet their least controllable part of the work that they do in public health. And then it was further noted that reporting and documentation systems that are constantly being restructured and repaired is also an issue. So errors and missing data can be very disruptive to the work that they're doing in public health. So, although we were faced with some pretty uncontrolled situations and uncontrollable variables, which we've learned can happen in natural experiments, delays and interruptions, we feel that we were still able to do good work that we hope will meaningfully contribute to making a difference in public health agency work. And while our journey was not straight from point A to point B, our course changes, redefining our case burden by looking at individual investigators, led us to insights about how public health work is conducted and could be improved. And we would just like to, this is a list of our project team and then the public health agency volunteer reviewers, and we'd like to specifically call out the folks at the Reagan Street Institute that are deploying and evaluating the pre-populated form intervention project led by Brian Dixon and his team. So thank you to the Reagan Street team for allowing us to peer into your work. So thanks, and we're happy to take questions.
All right, thanks so much. So we have two folks lined up to give commentary today. The first one is Shandy Dirth. She's the administrator of the epidemiology department for the Marion County Public Health Department in Indianapolis, Indiana. She's worked with infectious disease and emergency preparedness programs, and concentrates on health informatics and emergency preparedness. Our other commenter is Joe Gibson, who is the Director of Epidemiology for the Marion County Public Health Department in Indianapolis. He designs and implements analytic systems and tools for use in the department and the community, and collaborates with research faculty at several universities. His areas of expertise include maternal and child health and public health informatics and preparedness. Shandy, you want to get us started?
Sure. First, I want to say thank you for the presentation, and I'd also like to point out that I think there's probably other unforeseen value in the project, and that just first notifying those providers that this is a notifiable condition and contact public health in the first place probably has some value that's really hard to gauge in a research study like this. That's a big thing we come up against a lot in public health, is that providers don't even know they're supposed. That's why here in Indianapolis, we've been fortunate to have an electronic lab reporting system. That's really where we get most of those first initial reports of a communicable disease. But the more education we can do with the providers, the better. And I think, if nothing else, this research was kind of a door into so many providers around the country. So I think that alone is a positive of the project. I'm going to go ahead and defer over to Joe Gibson. He was actually much more involved in the project than I was.
Yep. Thanks, Shandy. They talked a lot about how the systems changed during the study, and that was certainly a challenge. One of the reasons we were able to work by it is that they had people here at the health department involved in the project. It took a lot of discussion and a lot of work with some systems people here to try to figure out what could be done, could not be done. But in the end, we were able to pull out a study that had some value to us. It was also really valuable. I was glad that we were able to get so much. I was glad that Debra and her team were able to do so much interviewing of the folks out here involved in the project. A lot of the value from this project was getting a better understanding, getting actually a written understanding of how the operations go here. And I think that also really informed the interpretation of the results that we saw. We saw some interesting patterns in looking at the volume, how volume changed by day of the week, some unexpected dips when reports were completed at 7 days and 14 days. And it would have been a complete mystery if we hadn't had some real qualitative interviewing going on during this process, so we could get a better grasp of why patterns happen. I guess those are my main 2 points. One of my big takeaways from this was value of having the researchers, having part of the research team get very close to the processes and people who are doing the processes. They could have a much more complete interpretation of the numbers.
Great. So Janet, Debra, or Ian, do you have any response to that? Like the answer is no. So we do have time for questions. If you have any questions, please type them into the chat box here, and we'll be happy to get them answered. But I do have a question. So, as kind of the HIEs and just EHRs become more ubiquitous, do you think you might see some greater familiarity with them in general, and how might that impact kind of what you found to date?
Can you repeat that?
So I think as things like health and HIEs and electronic health records become more and more kind of ubiquitous, a little more common, do you think you might find how might that change what you found to date? Do you think greater familiarity might, would that impact kind of what you've seen?
This is Joe Gibson.
Yeah.
We're pretty fortunate here in Central Indiana that we've got a fairly advanced health information exchange where they do capture all of the electronic laboratory reporting, and they have a lot of information about the providers and the patients from other medical record sources that are in their whole repository. So they were able to. It's not a lot of locations now in the U.S. have the ability to enhance that electronic. When the electronic laboratory report comes through, it's fairly sparse. There's not a lot of information on it. There's not a lot of information that identifies physicians or the patients. But because the HIE has a whole lot of other information about providers and patients in the area, they were able to enhance that data and complete much more of the form before it went to the physician. I think rather than the results of this changing as more HIEs and EHRs are implemented, this is probably a reflection of where things are going to go as more locations in the country have the same capacity and are capturing the same information, that they can take something as sparse as an electronic laboratory report, add good information about who the physician is, the name, the phone number, the patient's name and contact information, and get that onto these case report forms, get it to the physician to really decrease the amount of work that they need to do. And so you might see the speedier reporting of those cases back to public health so we can do the follow-up more promptly.
Great, thank you. We do have a question from Bob Harmon. Bob writes, what was the level of satisfaction of the disease investigators with the HIE data? How satisfied were they with the data they were getting?
So we were not, when we presented results of the analyses to reviewers at the public health department, the objective of that was actually to see whether or not, for example, a seasonal variation or an uptick, for example, in salmonella that we noticed in the analysis was something that was also observed within the health department by investigators. We were not doing a qualitative, there was not a qualitative component of this project where we were looking at level of satisfaction with the data that was received on in communicable disease report forms. We were just looking at what was actually available and available in the surveillance system, the two surveillance systems that we had the data pulled from. I'm not sure that answers the question.
And this study is kind of nested in another study that is looking at the quality, the effect of this intervention on the quality of the data that gets reported back to the public health department.
Right. I mean, yeah, and that's not right, Joe. I mean, because that's the work that I'm doing with Regan Streep. But I'm not sure, since it wasn't part of this specific study. I should probably put that aside.
Great, thanks. So, Joe, back to your comments about kind of, seems like you all have a little bit more of an advanced system than others might. So if you were to say there were some critical pieces of data to kind of get integrated into the system, you mentioned things like, providers and things like that. What would you say are the critical pieces of information you might want to put into, let's say, assure get entered into these records? You have any thoughts on that?
Yeah. The investigators really have appreciated that the health information exchange can augment the physician information. A lot of what happens, we get electronic laboratory reports from almost all of the clinical labs in central Indiana, and a lot of places around the country, more and more they're getting good access to the electronic laboratory reports that are coming out of labs, but those are usually pretty sparse, and it's often hard to tell who the provider is, who the provider is who ordered that lab. The lab is going to be getting the record back to the provider, but as a public health department, when you receive the report, it's hard to know who that provider is. And then even if you know who they are, you need to figure out how to contact them. One of the biggest values that the HIE has provided just in terms of our workflow here is that they're attaching physician names and telephone numbers to these electronic health reports because they have a table that has all the providers in central Indiana. Then our nurses don't have to spend nearly as much time just trying to track down how to get into contact with the providers. That's been a huge gain, and I expect that more HIE, that's a piece of value that HIEs can provide to health departments that we'll probably see more of as well. Same thing goes for patients. There are some diseases where we don't do a lot of patient follow-up. There's some where we do, and where we do, it's the same story. We really appreciate being able to not have to do all the detective work to figure out how to contact somebody. And the HIE just attach that information to the record.
Hey, Joe, this is Debra. So, one of the things that's somewhat unique in Indiana is it's a dual reporting state. So labs are mandated to report notifiable condition, or communicable infectious disease positive lab reports or results in Indiana, as well as providers are mandated by law to submit communicable disease report forms. In a state, though, where this was, so can you speak to, in terms of the workflow within the public health department, the lab reports are sent over very quickly. And as you said, they're transmitted very quickly to public health, but they don't contain all of this information that all of the required information that's of use for public health. And can you, so that it seemed like the audience maybe needed to also know that that's maybe something, as well as the fact that the Health Information Exchange in Indiana is, by far one of the most advanced ones in the country. That's also another thing that's different here.
Yeah, it was interesting because physicians are, generally the reporting rate from physicians is very, very low. It's under 10% for most diseases. So even though it's required by law that they report certain diseases, for most diseases we get less than 10% of the reports we should get from physicians. And when we started getting these electronic laboratory reports, some of the people running the system and physicians who were aware of it started to have the attitude of, look, you're getting this from the lab, we don't need to report it all anymore.
Right.
A valuable part of the larger study that this was within is we're trying to trim down the reportable disease reporting form so that we ask the physician only for the information that we don't already have from the lab report. So we're trying to make disease-specific reporting forms that they're just asking for what we don't already know about that specific case. And because of these electronic systems, we've got the opportunity to do that. And that's part of what we're testing in the larger study, whether we can still get, we can get improved reporting rates and better information with less physician burden because we're taking advantage of the HIE information and just asking the physician for the specific things we don't have from other sources.
Great. We've got a few more questions, looks like. So Ann Kelly wrote, based on these analyses, what would you suggest that other public health departments pursue who are looking to expedite their CD reporting processes? Where should they apply their efforts to encourage reporting by providers? Any thoughts on that?
Well, at this point, because most places in the country don't have access to the type of data that they have access to in Indiana, although we do see that as kind of the future, it's not the very near future for that to be happening in most places in the country. So I would just actually go back to what Shandy was commenting on, which is doing kind of constant re-education with providers about how using the practices of the agency wherever they are in the country, just reminding the providers what the practices are, and then working to kind of figure out the best internal workflows for the different agencies, because those are going to differ a lot. But I'm kind of hoping that, agencies would be, different agencies, even though they're different from Marion County, would be able to look at our data and kind of the data from our study, and then look within themselves and say, wow, some of these workflow issues can really make a difference in how things are processed within our own agency, which can affect the timeliness of our own reports. So I'm kind of hoping that that the findings from our study will, while we're all waiting for HIE to be implemented across the country, will be able to kind of improve their own internal processes.
This is Shandy. I would also suggest for those states that do not have any kind of electronic lab reporting at all, that you reach out to your Health Professions Bureau, that agency that actually licenses the physicians. Perhaps you could build a partnership to do some communication that way, or any local medical associations to get more information out there in newsletters. I realize not everyone reads every newsletter that comes through. It's going to take multiple steps to get there, but also we've linked in with, like say here in Indianapolis, a local infectious disease doctor does a really robust listserv of doctors around town, and he sends out health alerts that way, or just kind of a heads up when he sees something going on in his facility. Since we've partnered up with him, he sometimes will send out notices from public health. So we're not going to send out a list of 77 diseases to that doctor, but if we say, hey, we've got an increase in syphilis, and we need to remind everyone that this is a reportable disease, here's how you report, here's how you find this form to report it to us. He's always been very helpful in sending that out for us. So the more partnerships you can build that way, the better off you are, I think.
That's a great point, Shandy.
On the HIE side, health information exchanges around the country are really struggling to figure out a business model that's going to provide them with stable funding. So this is another way they can be providing value is enhancing these disease reports. Public health usually isn't a big funder for HIEs, but if you're decreasing the amount of burden on physicians, there's a win there, although, of course, physicians aren't especially good at reporting in the first place, so it's not like there's a lot of burden out there now if they're ignoring the law.
We have one last question. Jason Orr wrote, looking at the Washington notifiable conditions list, I see that there are multiple Washington Department of Health departments that receive these reports. Was that a factor in timeliness for notification by providers? For example, gonorrhea goes to ID and RH, while Hep A goes to communicable disease epidemiology. Do these cases then get routed from one central area to the LHDs? How does that work exactly?
This is Shandy. I can say for us here in Marion County, what we've done years ago is that data, when it first comes into the Marion County Health Department, it's separated in the database by disease to program area. So the nurse EPIs who investigate salmonella, they're basically getting salmonella and other diseases assigned to them, and then the STDs are sent over to our STD. So it's already separated early on that way.
And just to clarify that although the presenters of the study are located in Washington, the work was conducted in Marion County Public Health in Indiana, and the reason why we're far away but did the work there was because we were really interested in how a health information exchange that is as evolved as the health information exchange there can impact notifiable conditions reporting, and such a system does not exist yet in Washington. So the work was actually done with Indiana notifiable conditions.
Great. Looks like we are out of time. Thanks for your participation today. We have some upcoming webinars in February. And thank you for participating in today's webinar. If you have any questions or you need more information, contact Ann Kelly at the address below. Thank you.